What if I told you that your doctor might be withholding crucial information about your health after age 70? Dr. Richard Thompson, a retired physician with over 3 decades of experience, recently admitted that he and his colleagues routinely keep certain truths from elderly patients. We call it compassionate care, he explained, but sometimes our silence does more harm than honesty. The 7 secrets he shared with me will make you question everything you think you know about medical care for seniors. This isn't about doctors being malicious or uncaring. It's about a medical culture that believes protecting elderly patients from difficult truths is more important than giving them the information they need to make informed decisions about their own lives. But as Dr. Thompson discovered after years of reflection, this approach might be doing more harm than good. Stay with me until the end, because what you learn today could fundamentally change how you approach healthcare conversation with your elderly loved ones and potentially save lives in the process. Meet Dr. Richard Thompson. Dr. Richard Thompson isn't just any retired physician. For 35 years, he served as a cardiologist at one of the country's most respected medical centers, treating thousands of patients over 70. He was known for his gentle bedside manner, his thorough approach to care, and his dedication to his elderly patients. Colleagues respected him, patients loved him, and his reputation was spotless. But after retiring at 68, Dr. Thompson began questioning some of the practices he'd followed throughout his career. I started thinking about all the conversations I'd had with elderly patients and their families, he told me during our 3-hour interview. He realized that in trying to be kind and protective, I might have been taking away their ability to make truly informed decisions about their care. What prompted this self-reflection? The death of his own father at age 82. When my dad was diagnosed with advanced heart disease, his doctor, my colleague, treated him exactly the way I had been treating my elderly patients for decades. Dr. Thompson explained with what we thought was compassionate care, but as I watched my father navigate his final months, I realized he was making decisions based on incomplete information. He didn't understand his real prognosis, his actual treatment options, or what his quality of life would realistically be like. That experience changed everything for Dr. Thompson. He began reaching out to former patients and their families, conducting informal follow-ups and questioning whether the medical profession's approach to elderly care was truly serving patients' best interests. What he discovered troubled him enough to break his silence. Secret pound 1. We sugarcoat prognosis more than you realize. The biggest thing we don't tell elderly patients, Dr. Thompson admitted, is how serious their conditions really are. We use phrases like manageable condition or we'll monitor this closely, when we should be saying you have 6 months to 2 years to live. This practice, known in medical circles as prognostic disclosure avoidance, happens far more frequently with elderly patients than with younger ones. Dr. Thompson explained that physicians often justify this by saying they don't want to take away hope or cause unnecessary distress. But here's what we learned from patient follow-ups, he continued. In elderly, patients don't understand the reality of their prognosis. They make decisions they later regret. They undergo aggressive treatments that reduce their quality of life. They don't have important conversations with family members. They don't make peace with estranged relatives or take that trip they've always wanted to take. Dr. Thompson shared the story of Eleanor, an 84-year-old patient with advanced pancreatic cancer. I told her we had treatment options to explore and that we'd take things one step at a time. What I didn't tell her that her median survival was 4 to 6 months and that the treatments would likely make her sicker than the cancer itself. Eleanor chose aggressive chemotherapy, spending her final months in and out of hospitals, experiencing severe side effects, and missing precious time with her grandchildren. She died thinking she was fighting to get better. Thompson said quietly, if I had been honest about her prognosis, she might have chosen comfort care and spent those months making memories instead of making trips to the oncology clinic. This isn't an isolated case. Studies show that elderly patients with terminal diagnoses often have unrealistic expectations about their prognosis because physicians avoid direct, honest conversations about life expectancy. Sacred Pound 2. Age-based treatment rationing is real. This one's hard to admit, Dr. Thompson said, pausing for a long moment, but we absolutely make different treatment recommendations based on age, and we don't always tell patients that's what we're doing. The medical term for this is age-based rationing, and while it's not officially sanctioned, Dr. Thompson says it happens routinely. A 45-year-old with heart disease might be offered a heart transplant evaluation. An 85-year-old with the same condition might be told they're not a good candidate for aggressive intervention without being told that. Age is the primary factor. The reasoning, according to Dr. Thompson, is often practical. Limited resources, statistical outcomes, and quality of life considerations. We tell ourselves we're being realistic about what treatments will actually help elderly patients, he explained. But the problem is, we're making these decisions for them instead of with them, Doctor. Thompson shared the example of Harold, a remarkably healthy 78-year-old who developed severe aortic stenosis, a narrowing of the heart's main valve. 20 years ago, I would have automatically recommended medical management instead of surgical intervention because of his age. He told Harold he was too high risk for surgery without explaining that his age was the primary risk factor I was concerned about. Harold accepted this recommendation and lived with increasing shortness of breath and fatigue for 2 years before seeking a second opinion. The second cardiologist recommended valve replacement surgery, which Harold underwent successfully. He lived 8 more active, healthy years. Harold could have had those 8 years of better quality life if I had been honest about why I was hesitant to recommend surgery, Thompson reflected. He deserved to know that age was influencing my recommendation and to make that decision for himself. Recent studies support Thompson's concerns. Research shows that elderly patients often receive less aggressive treatment for conditions like cancer, heart disease, and kidney failure, not because the treatments wouldn't work, but because physicians assume elderly patients wouldn't want aggressive care or wouldn't benefit from it. Secret Pound 3. We overestimate your medication side effects. Here's something that might surprise you, Dr. Thompson said. We're often more worried about medication side effects in elderly patients than we should be, and it leads us to undertreating conditions that could significantly improve quality of life. This phenomenon, called therapeutic nihilism, happens when physicians become so concerned about potential side effects that they avoid prescribing medications that could actually help elderly patients. I had a 72-year-old patient, Margaret, with severe depression following her husband's death, Dr. Thompson shared. She was barely eating, couldn't sleep, and had lost all interest in activities she once enjoyed, but I was hesitant to prescribe antidepressants because I was worried about side effects like falls, confusion, or cardiac complications instead of prescribing medication. Thompson recommended counseling and lifestyle modifications. Margaret continued to struggle with depression for months before her daughter insisted on seeing a geriatric psychiatrist, who immediately started her on a low-dose antidepressant. Within 6 weeks, Margaret was back to her old self, Dr. Thompson admitted. She started socializing again, resumed her volunteer work, and her appetite returned. I had let my concerns about potential side effects prevent her from getting treatment that dramatically improved her quality of life. This pattern extends beyond depression treatment. Dr. Thompson explained that physicians often prescribe pain medications for elderly patients with chronic conditions, avoid blood thinners for patients with atrial fibrillation, and hesitate to recommend cholesterol-lowering medications, all because of exaggerated concerns about side effects. The irony, he noted, is that undertreating these conditions often leads to worse outcomes than the side effects we're trying to avoid. Secret Pound 4. Your family influences our treatment decisions more than you know. This is uncomfortable to admit, Dr. Thompson said, but family members often have more influence over treatment decisions for elderly patients than the patients themselves, and we sometimes go along with this even when it's not in the patient's best interest, Dr. Thompson described what he calls family override, situations where adult children or spouses make healthcare decisions for elderly patients who are perfectly capable of making their own choices. He had an 89-year-old patient, Robert, who wanted to continue driving. Dr. Thompson shared he had mild cognitive changes but was still functioning well and living independently. However, his daughter was terrified he would have an accident and insisted I tell him he couldn't drive anymore. Instead of having an honest conversation with Robert about driving safety and perhaps recommending a driving evaluation, R. Thompson chose to support the daughter's concerns. I told Robert that his reflexes weren't what they used to be and that it would be safer if he stopped driving. It took away his independence based on his daughter's fears, not on medical evidence. Robert became increasingly isolated and depressed after losing his driving privileges. He had to depend on others for grocery shopping, medical appointments, and social activities. Dr. Thompson reflected, his quality of life declined significantly, and I played a role in that decline. This pattern is particularly common around decisions about living independently vs. moving to assisted living, continuing to work or volunteer, traveling or engaging in physical activities, end-of-life care decisions. We justify this by saying we're trying to keep families unified and reduce conflict, Dr. Thompson explained. But in reality, we're often supporting family members' anxiety rather than honoring elderly patients' autonomy. Research confirms Dr. Thompson's observations. Studies show that healthcare providers frequently defer to family members' preferences for elderly patients even when those preferences conflict with what the patient has expressed wanting. Sacred Pound 5, we're not honest about what normal aging really means. One of the biggest disservices we do to elderly patients, Dr. Thompson said, is attributing symptoms to normal aging when they're actually signs of treatable conditions. This practice, known as ageism in medicine, leads to underdiagnosis and undertreatment of conditions that could significantly improve elderly patients' quality of life. I can't count how many times I dismiss symptoms in elderly patients as just part of getting older, Dr. Thompson admitted. Fatigue, pain, balance problems, memory issues, depression. I was too quick to assume these were inevitable parts of aging rather than investigating whether they had treatable causes. Dr. Thompson shared the story of Dorothy, an 81-year-old patient who complained of increasing fatigue and difficulty concentrating. He assumed it was normal cognitive aging and suggested she accept these changes as part of getting older. I didn't order blood work or investigate further. Dorothy's symptoms worsened over several months before her daughter brought her to a geriatrician who discovered she had severe vitamin B2 deficiency, a completely treatable condition. After B2 injections, Dorothy's energy and mental clarity returned to normal, Dr. Thompson said. I had let her suffer unnecessarily because I assumed her symptoms were just part of aging. This pattern is surprisingly common. Research shows that healthcare providers often fail to investigate symptoms in elderly patients that they would thoroughly evaluate in younger patients. Conditions like depression, sleep apnea, thyroid disorders, and nutritional deficiencies are frequently missed because they're attributed to normal aging. The truth is, DRD. Thompson explained, while some changes are part of normal aging, dramatic declines in function, severe pain, significant cognitive changes, and persistent depression are not normal at any age and deserve thorough evaluation. Secret Pound 6, we avoid discussing your real risk of falls and fractures. This might be the most important secret I'm sharing, Dr. Thompson said seriously. We know which elderly patients are at high risk for falls and fractures, but we often don't have direct conversations about this because we're worried about creating anxiety or limiting their activities. Falls are the leading cause of injury-related death in adults over 65, and fractures from falls often mark the beginning of a significant decline in independence and quality of life. Yet Dr. Thompson admits that physicians often avoid discussing fall risk in detail. I had detailed information about patients' balance problems, medication side effects, vision issues, and home safety hazards, he explained. But I would give vague advice like be careful or maybe use a cane instead of having serious conversations about fall prevention. Dr. Thompson shared the story of William, a 76-year-old patient with multiple risk factors for falls, blood pressure medication that could cause dizziness, mild balance problems, and cataracts that affected his vision. I knew William was at high risk for a serious fall, but I didn't want to alarm him or make him feel like he couldn't live independently. Instead of discussing specific fall prevention strategies, reviewing his medications, or recommending a physical therapy evaluation, Thompson gave general advice about being careful. 6 months later, William fell in his bathroom, broke his hip, and never regained his previous level of independence. If I had been honest about his fall risk and worked with him on specific prevention strategies, that fall might have been prevented. Dr. Thompson reflected, my desire to avoid a difficult conversation potentially cost William his independence. The medical literature supports the importance of direct fall risk discussions. Studies show that elderly patients who receive specific fall prevention interventions have significantly lower rates of falls and fractures, but these interventions only happen when physicians are willing to have honest conversations about risk. Secret Pound 7, end-of-life planning conversations are often too little too late. The final secret, Dr. Thompson said with visible emotion, is that we wait far too long to discuss end-of-life planning with elderly patients, and when we finally do have these conversations, they're often rushed and inadequate, despite medical recommendations that advanced care planning should begin early and involve ongoing conversations. Dr. Thompson admits that he often avoided these discussions until patients were already seriously ill. I would tell myself I was waiting for the right time to discuss end-of-life preferences, he explained. But the right time never seemed to come. Patients seemed to be doing well, families weren't ready to hear about it, or I was worried about taking away hope. The result, according to Dr. Thompson, is that many elderly patients end up receiving care that doesn't align with their values or preferences because these conversations happen too late or not at all. He shared the story of Anna, an 83-year-old patient with heart failure. For 3 years, I managed Anna's condition without ever asking what kind of care she would want if her condition worsened. I assumed her family knew her wishes and that we'd cross that bridge when we came to it. When Anna's condition deteriorated rapidly. She was unconscious by the time she arrived at the hospital. Her family, unsure of her wishes, chose aggressive care, including mechanical ventilation and intensive care. Anna died 2 weeks later in the ICU, surrounded by machines instead of loved ones. After Anna's death, her daughter told me that Anna had always said she wanted to die peacefully at home. Thompson said quietly, "If I had facilitated that conversation earlier, Anna could have had the death she wanted, and her family wouldn't be carrying the burden of uncertainty about whether they made the right choices." Bethern made the right choices. Research consistently shows that patients who engage in advanced care planning are more likely to receive care that aligns with their preferences and less likely to experience unwanted aggressive treatment at the end of life. Yet studies also show that these conversations often don't happen until patients are already seriously ill or dying. The impact of medical paternalism, Dr. Thompson's revelations highlight a pervasive issue in elderly care: medical paternalism. This approach, where physicians make decisions based on what they think is best for patients rather than providing information and letting patients decide for themselves, has been declining in medicine overall, but persists in elderly care. We justify paternalistic approaches by saying we're protecting elderly patients, Dr. Thompson explained, but in reality, we're often protecting ourselves from difficult conversations and uncertain outcomes. The consequences of this approach are significant. Seven events. Elderly patients make decisions based on incomplete information. Treatment options may be limited without patients understanding why. End-of-life care may not align with patients' values and preferences. Families are left with guilt and uncertainty after loved ones die. Elderly patients lose autonomy and dignity in their healthcare decisions. "I spent 35 years thinking I was being compassionate," Thompson reflected. "But I realize now that true compassion means respecting elderly patients enough to give them the information they need to make their own informed decisions about their care and their lives." What this means for patients and families, Dr. Thompson's admissions have important implications for how elderly patients and their families approach healthcare. Ask direct questions. Don't accept vague answers like "we'll monitor this" or "let's see how things go." Ask for specific information about prognosis, treatment options, and what monitoring actually means. Request honest discussions about age, related treatment considerations. If your doctor recommends against the treatment, ask whether age is a factor and request information about outcomes for patients your age who have received that treatment. Advocate for complete medication reviews. If you're experiencing symptoms that affect your quality of life, ask whether there are medications that might help and what the actual risks and benefits are for someone your age. Insist on autonomy in decision-making. Make it clear to healthcare providers that you want to be the primary decision maker about your care, even if family members have concerns. Request thorough evaluation of symptoms. Don't accept as just part of aging as an explanation for significant changes in function, energy, mood, or cognitive ability. Have honest conversations about fall risk. Ask for a comprehensive fall risk assessment and specific prevention strategies if you have risk factors. Initiate advanced care planning conversations early. Don't wait for your doctor to bring up end-of-life planning. Start these conversations while you're healthy and can think clearly about your preferences. Dr. Thompson's new mission. Since our interview, Dr. Thompson has become an advocate for more honest, direct communication between physicians and elderly patients. He now speaks at medical conferences about the importance of abandoning paternalistic approaches to elderly care. "I can't change the decisions I made during my career," he told me as our interview concluded. "But I can encourage other physicians to have the honest conversations I wish I had been brave enough to have." Dr. Thompson is also working with medical schools to train future physicians in respectful, direct communication with elderly patients. We need to teach young doctors that respecting elderly patients means giving them the information they need to make their own decisions, even when those conversations are difficult. His message to current elderly patients is simple: demand honesty from your healthcare providers. You've earned the right to make informed decisions about your own care, and any physician who tries to protect you from information is doing you a disservice. The path forward, Dr. Thompson's revelations are uncomfortable, but they point toward a better approach to elderly care, one based on honesty, respect, and shared decision-making rather than paternalistic protection. Elderly patients aren't fragile children who need to be protected from difficult information, Dr. Thompson emphasized. They're adults who deserve to understand their health conditions, their treatment options, and their prognosis so they can make decisions that align with their values and preferences. This shift requires changes from both healthcare providers and patients. Healthcare providers need to abandon paternalistic approaches and commit to honest, direct communication with elderly patients. This means having Difficult conversations about prognosis, being transparent about age-related treatment considerations, and respecting elderly patients' autonomy in decision making. Patients and families need to advocate for complete information and shared decision making. This means asking direct questions, requesting honest discussions about prognosis and treatment options, and insisting on being the primary decision maker about care. The medical profession has made significant strides in moving away from paternalistic approaches in most areas of care. It's time to extend this respect for patient autonomy to elderly care as well. Final thoughts. Dr. Thompson's decision to speak openly about these issues took courage. By admitting to practices that he now recognizes were problematic, he's opened important conversations about how we can improve care for elderly patients. We hope other physicians will examine their own practices and ask whether they're truly serving elderly patients' best interests, Thompson said, and I hope elderly patients and their families will use this information to advocate for the honest, respectful care they deserve. The goal isn't to make physicians seem uncaring or malicious. Most doctors, like Dr. Thompson, genuinely want to help their patients. But good intentions aren't enough if the result is that elderly patients lose autonomy and don't receive the information they need to make informed decisions about their own lives. Elderly patients deserve the same respect, honesty, and shared decision-making that we provide to younger patients. Dr. Thompson's admissions are a reminder that true compassion in medical care means respecting patients enough to tell them the truth, even when that truth is difficult to hear. Thank you for watching this important conversation. If you found Dr. Thompson's insights valuable, please share this video with others who might benefit from this information. Your sharing can help elderly patients and their families advocate for better, more honest care. Please comment below with your own experiences with elderly healthcare, and don't forget to subscribe for more content that challenges assumptions and provides information that could make a real difference in your life. Remember, advocating for honest communication with healthcare providers isn't being difficult. It's being responsible for your own care and ensuring that you can make the best decisions possible about your health and your life.